Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. We're continuing our discussion with Jim Ally regarding PAs and leadership roles. Jim, I was hoping you might share with our listeners a little bit about a PA-owned clinic. What kinds of things would you tell our listeners that are interested in starting a clinic? What do you need to do? How do you need to start? Where do you need to go? What kinds of things do you need to think about?
So first thing I would say is if you're going to start your own practice as a PA, it's really important that you check either with your board or the state statutes relative to your ability to own and operate a medical practice. Usually in the underserved communities, there's flexibilities built into, and it wasn't in Arizona, flexibilities built into the ability to open a practice because those underserved areas really need to be served. And so I went to my medical board here and said, I knew the chair at the time, and just said, Randy, this is what I want to do. What do you think? And he said, well, the statutes are clear. If it's underserved, that okay, but you need your supervision and that. And I said, yep, no, we had that all covered. So the first things first, you check with your state statutes about whether or not you can open a clinic before you do anything else. The second thing I would say is I would look at underserved because a lot of insurers, particularly the commercial insurers, some of them like Blue Cross still does not reimburse PAs directly in many states. So you have to have somebody else like a physician and do an incident to, et cetera, which really the point I'm making is you have to check what contracts can you get reimbursed for your services. Because if you don't know what that is and you open up a clinic and you're going to put some money up, it's going to cost you some money. Even if you're renting space and you're buying furniture and all that, it's going to cost some money. So you want to know that you can get reimbursed for the services that you want to perform. Congruent with that process, if this is something you want to do, you have to write a mission statement. And a mission statement will really drive what's known as a business plan, because if you want to go for capital to a bank or some lending institution, you have to have it. They won't even talk to you without it. And everything will be built from the mission statement. Then you do something like a SWOT analysis, strengths, weaknesses, opportunities, and threats in the marketplace that you want to be in. And between the mission statement, the SWOT analysis, and that you can actually develop something called features and benefits. What are the features of what you want to do? And then what are the benefits to the community, and for that matter, to the insurers for you performing these services? Underserved, that's an easy call, right? You're providing services, you're giving access where there's no access at this time. And then get real familiar with value-based care. There's a big push and not just primary care, it's across the board, to move over to value-based care. And Medicare says that by 2030, they want 100% of their ACOs on value-based care. So knowing and understanding value-based care will be, I think, start with it being important, but eventually be crucial for the success of a practice.
Jim, please tell us a little bit more about value-based care and the models. What is that, and where did it come from, and how does it fit into kind of everyday practice?
Yeah, this is an hour lecture, so I'm going to try and encapsulate it in 5 minutes. So there's really two models for reimbursement. One is a fee-for-service model, which is what most of us are under today. And in the fee-for-service model, you can be just a practice, and it doesn't matter what practice. It could be an orthopedic practice, it could be a primary care practice. And so there are some fee-for-service components outside of bundling that we see in surgery. And so those are all just paid at whatever the rate is for that particular code. Right? You're coding for that reimbursement. But let's stick with primary care because it's the simplest to explain. So in fee-for-service, straight fee-for-service without anything else, you see a patient, you do whatever you do, you write your note, You check a 99213, 99214, and you get reimbursed at whatever rate is the allowable for that, whether it be Medicare, Medicaid, or a commercial plan. The second level of fee for service is a fee for service where you can kind of put your toe in and talk to your contractors, including like the Blue Crosses and the commercials, and say, hey, we want to dabble in this. We want to stay in fee for service, but we'd like to start working on some measures. So we want to control, diabetes better. We want to control hypertension better. Want to make sure women get their mammogram, whatever it is that your practice is comfortable for, and your insurer will give you those measures. And so you can make additional money by meeting those measures that are set by the insurance company. There's a third level of fee for service, which gets into this is where the complexity comes in. It's where you commit to you're a bigger clinic now. So the first two could be any size clinic. Bigger clinics, over 25 providers, and the big system, institutional clinics, they can get into the CPC 1 or CPC. And that's where the insurer, particularly Medicare, will give you some money up front to help you kind of hire people, because you need people like care coordinators and others that can actually get the people navigated through the healthcare system and make sure they come back to you after a hospitalization or rehab visit or whatever. And then the fourth fee for service is for large institutional organizations where, let's say, you spent $10 million last year on all your patients. Well, Medicare will give you like eight of that $1 million up front. And if you keep the cost of them down below that, they'll give you a big bonus at the back end. So instead of getting 10, you might wind up with 14 or 15 million. So that's the fourth level, rather, of fee for service. Value based really has three components to it. First component is what they call an ACO, Accountable Care Organization. And accountable care organizations are large organizations that have networks of practices, and networks usually include primary care and specialists. Stay with primary care again, it's the simplest reimbursement model. And the ACO contracts with Medicare, they do the contracting for you. And so they would go and say, okay, our network spent $100 million last year. We're going to keep it under that amount by 80. We'll go to $80 million. And if we achieve all the goals, then Medicare will give them $150 million. And they're obliged to distribute those extra profits to the practices within their network. A large ACO actually bought my practice because they wanted our contracts. We had really great contracts with Medicaid. And so that the ACO is the first model, and it's a good model for practices that want to get started, but they don't have the ability, either relationships or capital or other, to get their own clinic off the ground. So they could join an ACO and get the benefit of the value based and get the direction by the value based through the ACO. So that's one value based model. The second model really is more procedural based. And that's the surgeries, other long-term and expensive items are bundled, and you get a flat fee for that service. Now, there are services outside of that that everybody does, and it's fee for service. Same game. If you're doing fee for service and let's say you reduce the rehospitalization because your infection rate is really low as a surgeon, or you're able to get the patient out of the hospital sooner because your rehab is faster or whatever. If you're saving Medicare, Medicaid, and the insurance companies money, they're willing to share some of that with you under the bundled service model. The third component is called the patient-centered medical home, and this is what we became in our practice. In the patient-centered medical home, it's a place where the patients are assigned to you, and you become responsible for all of their primary care. And so you get some fee up front, a per member per month fee to help pay for that care coordination. You get some other capitation monies up front to help you kind of get the logistics going, because you have to really change the way the practice flows. I mean, there's a lot of kind of inner workings that have to be changed. Now, it's costly. And so Medicare, Medicaid in particular realize that it's costly. So that's why they're giving, they call it a capitation. We call it a per member per month, but they gave us money up front to make these transitions into the value-based model. You would have share savings for hospitalizations, not so different from what we did in the first model with the SMIs. If you save the hospital the money on what that patient cost last year, so everything's based on a year to 18 months previous, then you can get a shared savings. Could be $50, could be, 10,000, 100,000, whatever it is. The other money is when you meet what they call a metrics or measures. So they give you, there's usually 12, there's about 20 of them, but they use 12 that are most critical to your patients. And usually it's diabetes and hypertension and COPD and getting colorectal screens and, all of the usual stuff. And then there's usually something that's like, let's say you have a lot of pediatrics. Well, now you got to make sure immunizations are up to speed, or so there are a couple of nuances, but by and large, the 10 are pretty much standard in the patient-centered medical home model. That's a Medicaid model. It's only Medicaid. There's no Medicare. The ACO model has been very successful for Medicare, and the PCMH model has been very successful for Medicaid.
Yeah, it's a lot of information, a lot of different models. My practice, we actually did that bundled service. And basically, let's say somebody needed a total knee replacement, right? So you took the patient, did all the pre-op surgery, post-op, but then it also went over into, the post-op visits, like if they needed a Doppler ultrasound, if the home health nurse needed to go out, there was a case manager who was the liaison. And you basically, once you got that patient, you took their care and you took care of them, all the way through. There was no bouncing back and forth or referrals. And the same thing, there was outcome measures. I think you made more with, positive outcomes. If you had a lower rate of readmission for whatever reason, lower rates of infection, you made more money. And it was okay. And I don't know that they're still doing it. I think they're probably doing it on some level, but I don't think it's an ongoing thing. So, anyways, that was my experience with that. But I did want to ask you a question. So, I when I hear about PA led practices, it's usually a primary care thing. I've had PAs that have worked, had their own business, but it's like a first assistant role or whatever, where they have a little cohort of surgeons that they rotate around with and they do their first assisting and maybe round on them or something like that. Is there a way that PAs could actually open a clinic in an orthopedic kind of idea where you're doing more of like a primary care musculoskeletal thing? Is that even a feasible thing to do? And if so, what kind of obstacles would you have?
That's a really good question. The answer is yes, you can. It's good, but it's going to take. So there's not a lot of that out there. There's not even a lot of information out there about it. But been asked that question multiple times, and I've given it a fair amount of thought. The number three debilitating condition in the United States. What do you think it is? Do you have any idea what it would be?
The number three debilitating condition, back pain would be my guess.
Pain in general. It's
Oh, just pain in general. And back pain makes up a big part of that, as I'm sure you know.
So, and there are practices where non-physicians own like interventional clinics where they bring an interventionalist in to do the injections, like some sort of epidural or facet or nerve root block or whatever, as long within their the scope of their license. And as PA's licensure expands, and it's expanding, it's not expanding as quickly as we'd like, but because we're showing that we're skilled and we have the competencies, we're able to do more and more within our own practices. That's where I think it would be a fairly easy startup. And when I say easy, it still has all the issues of primary care. Can you do it? You got to see what your legislation says. Can you get reimbursed for it? But if all those things are yes, 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 then I think, chronic pain. I don't know that PAs will ever be the primary surgeon, but I never thought we'd get as far as we are now. So who knows? Who knows?
Well, let me give you my idea, and you tell me what you think, if it's a total dud or if it could work. Um, so I am like an injection guy, right? I am, if you need a shot, you come and see me. I had patients that would come from way away to get an injection because I'm good at it. I teach it, I'm good at it, whatever. So could I open, or say, a injection clinic where it's nothing but MSK injections, knee injections, stroke, enteric bursa, whatever, and would that be something that I could do as like a fee for service, literally, where I only charge a certain amount? Would that exclude me from, Medicare, Medicaid? Would it be more realistic to kind of just focus on underserved with that? What are your thoughts? I'm just curious. And again, we're going down Sam's personal ideas here, but I'm just curious, and it's my podcast, so I can talk about what I want. So what do you think?
Well, and we're here collaborating, right? This is all part of the collaborating, sharing information for the betterment of our profession. So absolutely happy to talk about it. But I think it's very doable. I think that you have to check, you've said it, you have to check the boxes. Yep, legislatively, statutes say I can do it. Yep, the insurance company said they're going to reimburse me for it. Yep, I've got the patient base to, start this practice, all of those sort of things. And there's absolutely no reason not to. But I would urge you, sit down and write a business plan, because things will pop out when you write that, that will give you like a heads up, or even moments to pause and know that, oh yeah, I got to watch out for that. Or, hey, maybe we need to make a slight detour right here before you bump into the block. And then you got to make the detour. That's more costly than thinking it out before it happens.
Jim, that does make great sense. What I really am interested in is, you had mentioned this in your article, PAs being the transformative change for healthcare that we need. Can you elaborate a little bit on that?
I've read dozens of articles about the problems associated with our healthcare system, and they all seem to come back to two things: primary care and reimbursement. Two things. I mean, they'll filter down 30 pages, but you can encapsulate it into those two buckets. And so if you look at, let's go with reimbursement. Most democracies in the world spend 8% on primary care. United States spends 4.5%. So we spend almost half of what all the other democracies do, but our overall dollar amount that we spend per capita is dramatically higher than any other country in the world. And it has to do with, we've got this imbalance of too many specialists and not enough generalists. PAs can be the vanguard in making this transition, but they have to change the reimbursement model. And that'll include PAs getting paid equal to what a doctor gets paid. And that'll include funding up to 8% in primary care, which means Medicare's got to pony up some money. But I show clearly through budgeting that the downstream spend, not just the surgeries, but in general, the downstream spend, including ER, hospitalizations, specialty care, everything is significantly altered. There are multiple articles that support that. If you go in underserved primary care, right, and you're value based in your model, the income potential, because the cost potential is substantially lower, is greater than it is in most specialties. With primary care, you can get pretty much all of your school loans paid, and they put a halt on the interest. So you're not accumulating interest. So after 4 years, you could theoretically have all of your PA school loans paid for.
Well, Jim, I tell you, I've had a great time talking to you today. We've covered a lot of information. Folks, Jim Ally, and he's the president of the SPAFM. Thanks for coming on today.
Well, thank you, Sam. It was my pleasure.